Good evening, everyone. Thank you for joining me today in the 12th Congress on Cancer Research and Therapy. I would like to thank to the scientific team of the WCCRT 2026. My name is João Paulo Matushita Jr., and I am an interventional radiologist here in Brazil in the one and only cancer center called Camargo. And now let's discuss an innovative case where the use of new technologies prevented the progression of an oncological disease. I have no conflicts of interest. Percutaneous cholangioscopy or transhepatic cholangioscopy was first described in two publications in 1985 and remains indicated today in cases where conventional per-oral cholangioscopy is inaccessible or ineffective due to inherent technical limitations. This includes patients with surgically altered gastrointestinal anatomy or difficult to access intrahepatic lesions, such as intraductal pathology. Initially, urological or even endoscopic devices were used. However, due to the large caliber of these devices, new materials were developed for this purpose. The Review catheter is a 7.5 single-use device, and important to say that the previous devices that I told about lately in the previous slide, the endoscopic devices and the urological devices were 9 French, 14 French, or even 16 French, a very large device. So 7.5 French is a very thin and modern device because we have to make a hole in the liver to access the biliary system. It is an operator controlled and designed to provide a pathway through pancreatic biliary anatomy for diagnostic and therapeutic tools. Here you can see the disposal of our team during the procedure. Some technical issues about the device, and here's a picture of the device. I want to present a case in which this innovative device proved indispensable for optimal patient treatment. It's a case of a 55-year-old male patient with recurrent pancreatitis episodes since 2021. For everyone to understand, a pancreatitis is a serious inflammation of the pancreas that can be caused by various reasons, including inadequate drainage of pancreatic juice through the main pancreatic duct that is in here. Here's the relation of the pancreas and the duodenum, the biliary system, the gallbladder. To investigate the cause of pancreatitis, the patient underwent endoscopic retrograde Cholangiopancreatography. It's an ERCP, where a large duodenal diverticulum was identified. At that time, the surgical team attributed this diverticulum as the cause of the pancreatitis, and the patient underwent a type of surgery that by removing the portion of the duodenum where the suspected problem was located, obviously, alters or changes the intestinal transit, and this surgery is called Roux-en-Y gastric bypass. Nevertheless, the patient continued to suffer recurrent pancreatitis episodes, ruling out the duodenal diverticulum as the etiology. The patient searched for emergency department now in July 2022 in our hospital, and the surgical team suspected that the pancreatitis episode was caused by a biliary stone that was demonstrated on MRI imaging. This is the MRI imaging, and the blue arrow here shows the black spot here, that's the calculus. So since the alteration of the intestinal transit because of the prior surgery in 2021, the Roux-en-Y reconstruction, ERCP was not technically feasible. That's why I was then involved in the case. They called me to perform initially biliary drainage, which confirmed the presence of the choledocholitis. Here is the filling defect that shows it. I put it out with this balloon and I keep the drain in here. The patient was discharged from the hospital on the next day. However, a few days later, the patient was readmitted to abdominal pain. A perihepatic collection was diagnosed. Here you can see both MRI imaging, the coronal and axial imaging, both tissue images. Here's the collection, the blue arrow pointing the collection. Likely resulting from bili extravasation at the site of the insertion of the biliary drain in the left lobe. Due to the presence of the collection at the drain insertion site, I drainage the disc collection site here. So I put a drain in the collection here, and I change the lobe of the biliary drainage. So next day, discharged from the hospital with symptomatic improvement, but he continued making episodes of pancreatitis. But why the pancreatitis? Due to no defining the exact cause of recurrent pancreatitis, our team evaluated the images of the exams performed at our hospital in 2022 at the time, and we also requested description of the prior surgery in 2021. Upon reviewing the imaging studies, I noted that the main pancreatic duct was dilated since the CT scan performed before the initial biliary drain, and a stone was observed within the main pancreatic duct causing upstream dilation. Here's the stone and MRI imaging in the biliary, the pancreatic duct dilation. So it was confirmed by MRI also. That day I left the hospital and I called my father, who is an old school interventional radiologist, and I told him about the case. I told him about the images, and I asked what should I do, and then he asked me, why don't you puncture the pancreas and remove the stone from there? At that time, I thought my father was crazy. How would I puncture? I put a needle directly in the pancreas, put a hole on it, and access the pancreatic duct. But I respected my father and his idea, and I decided to study about it. Indeed, there were 2 case reports in literature describing percutaneous pancreatic puncture to access the main pancreatic duct in patients with altered intestinal anatomy, both showing direct punctures of the main pancreatic duct, US guided. The patient was then recalled to the hospital to try a maneuver that my father suggested. Therefore, I proceeded to puncture the main pancreatic duct under ultrasound guidance, confirming the diagnosis of a stone within the main pancreatic duct represented by this filling defect here. Through the access of the main pancreatic duct in here, I advanced a microwire and looped it through the biliary access, and I created a wire loop between the biliary system here and the pancreatic duct. With the support of this wire loop, I was able to successfully remove the stone from the main pancreatic duct. Here is the balloon, removing the stone here. This is an extremely important fact, since the alternative treatment would be remove half of the pancreas and the remaining duodenum, and thus I maintained an access to the main pancreatic duct through the right lobe of the liver through the biliary access. On follow-up imaging, we can see that the main pancreatic duct is not as dilated as previous exam. 2 months later, all drains were removed, concluding the treatment of the patient. Okay, patient remains asymptomatic and without new symptoms of pancreatitis. According to the patient, the longest period free from hospitalizations due to pancreatitis until April 2024. Almost a year and a half after the end of the treatment, the patient presented with a new episode of pancreatitis and was admitted to another hospital. The patient underwent biliary drainage by another team at an outside hospital, believing that the problem was again a stone in the common biliary duct, similar to us almost 2 years prior. Therefore, we called the patient to repeat the procedure, and thus we created a new wire loop and a stone removal. All again here. It's the biliary, the balloon removing the calculus in the main biliary duct, the excess that we do in the pancreatic duct, the wire loop, all over again. Here, the wire loop, and here, biliary excess, pancreatic duct excess. But this time, we maintain two excesses, one for the biliary system, and the other one through the biliary to the pancreatic duct, so that we could visualize the main pancreatic duct with the aid of the cholangioscope, which in 2022 we did yet have access to in Brazil. 5 months after biliary drainage, the main and maintenance of the biliary access to the main pancreatic duct, we advanced a sheath. Here's the sheath, and through the sheath we advanced the cholangioscope. And to our surprise, we visualized a polyp in the proximal portion of the main pancreatic duct. And we biopsied, directed, visualizing it. Without the aid of the cholangioscope, this would never have been possible. We also visualized the presence of several other polyps in the distal third of the common biliary duct. The presence of these polyps would explain the formation of all the stones that obstructed the pancreatic duct and caused the pancreatitis episodes. Here you can see a narrowing in the distal portion of the common biliary duct, maybe because of those polyps. That's why we treated with a fully covered stent for subsequent removal of this device after histological diagnosis, and we maintain the access of the biliary system through a sentinel drain. This time, the patient had a huge pancreatitis after the procedure due to the manipulation of the main pancreatic duct, but discharged from the hospital after 6 days. The histopathological diagnosis of the polyps was type of intestinal adenoma, initially benign, but with a potential to malignization. That's why we should have to stay following this patient up. Unfortunately, to follow him up, we have to maintain the drain, but we are not going to maintain the drain for the rest of his life. So we decided to remove everything because we couldn't offer the patient no other treatment percutaneously. However, knowing the cause of the recurrent pancreatitis and knowing that the patient should undergo surgery, the case was discussed with the surgical oncology team, and the patient was then referred to a duodenal pancreatectomy. This was a representation of the surgical specimen, and the pathological examination of the specimen confirmed the findings of adenomatous polyps, confirming the findings observed on cholangioscopy. Due to the unprecedented nature of this case, it was reported in one of the leading journals of interventional radiology at the end of last year. So, what is the clinical importance of this case? Without the use of the cholangioscope, we would never have visualized the polyp. The patient is relatively young and was at risk for malignant transformation of the adenomatous polyps in the pancreatic, and biliary duct. Digital cholangioscopy was essential for establishing the diagnosis and guiding all of the team through the better therapeutic management of patient. So what did I learn from this case? Interventional radiology transcends barriers. Challenging but achievable access routes have to be thought. We must not accept limitations. Cholangioscopy was a determining factor in the patient diagnosis and in defining his management. Thank you again. Thank you very much for your attention and have a very good conference. Thank you.